So, Allie, earlier this year, as you know, I got gender affirming top surgery in the form of a breast reduction. And I kind of regret it. Dun, dun, dun.
Wow.
The clickbait, the intrigue, the drama.
We'll be right back after this ad.
Yeah, exactly. People wanting more. Just kidding. I feel very neutral about it. So essentially, I got a breast reduction instead of a full double mastectomy because I, notoriously was a K cup. My tits were massive. I'm not even trying to. No, I was like a K or like an L. It's not even a joke. That's literally just the size that I was. I don't know why you're laughing. That's literally
I'm laughing
just what it was.
because the K cup, it made me think of coffee K cups. Like, I was just like, wait, what is that?
What is that? No, it's so large, it's unimaginable. And so I was like, I cannot imagine going from that to not having tits at all. And so I thought that the breast reduction would be a great middle ground. The issue is, as your body changes and kind of settle into it, because you're very swollen for like 6 or 7 months, where it's like, it's not actually what you look like. It's not what you're going to look like because you're so swollen, and boobs obviously hang a little bit. They are now a tiny bit bigger. And I am kind of like, oh, should I have just gotten the double mastectomy? Because I think that's the beauty of the double mastectomy is like, it's just gone. But if you get the breast reduction, they can kind of shift and grow back again, is the kind of sick thing.
Interesting.
But overall, I feel very mostly affirmed. And if anything, just maybe wish they were a tiny bit smaller. So I don't actually regret it. And I actually would recommend it as a midway point for maybe people who were in a similar situation. I can always go back under the knife if I want to go do that again. So that's my story, and I'm sticking to it.
Wait, okay, you said they're bigger. So they're bigger than when you first got the surgery and what you thought they would be, or they're bigger than originally?
No, that'd be so fucked.
Okay.
No. They're like a fucking like a quarter, half the size of they were originally. It's just when when you're fresh out of surgery, they're so tight. My nipples are like pointing to the fucking sky because you're so tight and so swollen that you're like, surely this is what my tits are gonna look like forever. Gravity just does what it does. So now I feel like instead of being stuck up to my neck, essentially, it's just like they hang like boobs normally would. And so they're just a little bit bigger. And I'm like, yeah, it's fine. I think what's beautiful is I no longer have to think about my tits with clothing. That was the most frustrating and hard thing with having gigantic boobs. And now I just throw on a shirt and I just look like a girl with like a C or a D cup. And honestly, that's wonderful. That's all I could ever asked for. So.
Oh my God, totally. Yeah. It's so fun to talk about surgery because I also have things that I would change about mine. Like they gave me like these weird steroid shots and didn't tell me that made the skin really delicate. And so I just took a shower and I ended up like fucking up my scars. It was just like a weird healing thing. So I think so many people, when it comes to surgery, it is like the doctors will even tell you, we don't know what will happen. But I think what was nice for me is like in my pre-surgery meetings, we went through and itemized very specific things that I wanted. So like exactly what you're talking about. I wanted to be able to throw on a shirt and have this, and this worry gone. I wanted to be able to feel a little bit more free with this. So I got everything feeling wise that I would want. And then also, bodies are organic. Surgery is big.
It's more wizardry than medicine, honestly, I feel. Because it's just like, they do what they can, and then your body's just going to do what it's going to do, and you just don't know. And it's like about genetics. Yeah. What was nice for mine in terms of you talking about being able to choose what you wanted, because it was a breast reduction, I did not want to go to someone who was like, yes, you are a woman with breasts, and we will be reducing them. So I went to this amazing this person does a lot of top surgeries, but also like they did like some gender affirming breast reductions, which I feel like is an option you don't hear as much. But so that was super cool. And beyond that, it's just like your body's going to do what you're going to do. But there are so many like cool things that surgeons can do now, specific things that they can try to target for your different gender goals, including various kinds of bottom surgery like vaginoplasty and phalloplasty and things like that.
Totally. Yeah, that's what's really interesting about today's episode. I feel like I didn't really know that much about bottom surgery until I talked to our guest. And she's just like a total wealth of information on this topic. Her name is Kayla McLaughlin, and she's a physician assistant at a hospital here in LA. So she basically talks to patients who are looking into getting gender-affirming surgeries. And her whole job is education about that process. So that was awesome.
Oh. That's so good. That's so good because I feel like these things can feel very, not scary, but like overwhelming when you're beginning these journeys. Yeah. I don't know, the fucking 3 therapist letters, all the crazy fucking shit that you have to do. So to have someone guide you through it and hopefully to have this episode to guide you through it, it's a beautiful thing. It's a beautiful thing. Yeah. Let's get into it. Let's do it.
Beyond cis male, cis female, non-binary, trans male, there are more.
They're swimming in like the gender soup of different experiences.
Gender is like a marker of time, thinking critically about what inclusion means.
So much of womanhood is tied to whiteness, is tied to thinness.
How do I identify myself? Faggot.
Non-binary.
As femme as humanly possible.
I'm a cisgender gay man.
A binary trans woman.
Theatrical and flamboyant. Dykes who identify as twinks.
A gender conscientious objector.
I just kind of forget that I have a body.
Drag helped me unlock the power of my femininity within a masculine persona.
Transitioning when you're older.
It opens up an entire world of possibilities. I bloomed. I blossomed.
Comfortable in my physical body for the first time in my whole life.
Existing
in a more nuanced way.
In thought, in imagination, in fantasy.
My gender in my head feels like the cosmos. Just fully unknowable, even to myself.
I wasn't trying to be a gender. I wasn't trying to be a race. I was trying to be a point of energy in the universe.
That's amazing.
I love that.
Let's start with what it looked like to choose this line of work. What drew you to this specifically, or did you set out with your medical job aiming for this?
Sort of. So I'm from rural Pennsylvania. Not crazy rural, but like pretty rural. I was the first person in my family to finish high school. So whenever I got into higher education, I was really interested in basically how other groups receive healthcare and what that looks like. So during my PA school training, the first year is all classroom teaching. And then the second year, you go out and do all your rotations through. It's basically like a mini residency in a sense. And whenever I did that, I went all over the United States and then also to South America, focusing on different disciplines of medicine. So like dermatology, psychiatry, family medicine, but within minority groups within the United States. So I was in Yuma, Arizona, doing pediatrics with kids who are undocumented, or maybe their parents are undocumented, who may be seeing a doctor for the first time when they're like 5 years old, something like that. I was on the Blackfeet Indian Reservation in Montana, and sort of the specifics of the group, they're important to know. But what you're really sort of learning is how you abandon all pretense or thoughts about or opinions of a group of people, and like learning how to be a little bit scrappy and like make accommodations for someone based on a religious, cultural, socioeconomic context. So when I graduated, one of my mentors, she was a few years ahead of me in PA school. She was working at the LGBT Center here in LA. And so I got a job there in HIV research, clinical research. And then I started doing hormone starts for trans patients. So the LGBT Center, it's a really large federally qualified healthcare facility. So they tailor specifically to LGBT folks. But it's also, we do like primary care. So I would be seeing people for just like regular asthma and that kind of stuff. But they also happen to be like taking and starting hormones.
Wow.
And it was just really fascinating. When I talk to different healthcare providers, I'm like, it's such a great area of medicine to be in because you just watch people transform. There's bumps in the road for everybody, and some people it's a difficult path, but our patients are very motivated to start their transition, and you see people really blossom, especially with surgery and that kind of stuff. So then after I was at the LGBT Center for a few years, in 2014 was when the federal law changed in terms of coverage for transgender surgeries. So all these federal employees were eligible for trans services. And then a lot of states, and of course, California started to follow suit. So a lot of places had a ticking clock of they had to be able to start offering these surgeries to their patients. Mm-hmm. So Kaiser started a surgery team, and then they were looking for a PA, and I applied. I didn't have a lot of surgery experience. I had done a surgery rotation in school, but nothing really since then. But they didn't really have anyone else who had had experience with trans patients. And I had only seen trans patients for like 3 years at that point.
Wow.
So I've been there since 2018. Yeah. And it's just grown. It's a regional program. So we see like a large area we do all of Southern California, and we do bottom surgery, and some programs have been added. So when I first started, it was just vaginoplasty, but now we do also phalloplasty and some non-binary surgeries also.
Wow, that's so cool.
We also get to see people who are intersex or who have disorders of sexual development that for a long time really didn't have anywhere to land in terms of a surgical intervention. People would typically go to like urology or maybe gynecology or just plastics, but without having that sort of specific gender experience. It's been great to see those patients too.
Totally. Who kind of had nowhere that they easily fell, and to kind of have like, oh, this is a basket for you. Yeah, that's very cool. So you said that you're doing a lot of bottom surgery. Would you run us through frequently asked questions and their answers? Is this a big part of your job? Because I feel very lucky to be in Southern California, where I could find a doctor and get a lot of these questions answered. But this podcast is just so far reaching. So maybe for people who don't have a doctor that they can ask these questions for, it sounds really fun to run through what are these top questions.
Totally. Yeah. So for trans feminine surgeries, there's vaginoplasty. And there's also something called phalloplasty, which is where we basically make the exterior genitals, but we don't make the vaginal canal. There are a few different techniques in terms of how the dissection of the canal is done. Some of the big questions are, is the vaginal canal self-lubricating? Which it is not. So we use the exterior genital skin to line the vaginal canal. So it's like skin similar to like your hand. Mm-hmm. But I always tell patients, I think a lot of trans feminine women think that maybe needing to use lube during sex is like abnormal or something that cis women don't do during sex. And I tell them like anyone over 30, she's using lube. So not a big deal there. Another thing is that electrolysis or like hair removal is required for any skin that's going to go inside of your body. So whether that's the vagina or whether it's a urethra for phalloplasty, electrolysis takes a long time. It's also pretty expensive. But if it's something that if you know you're going to transition down the road, just start doing that process, because that's really the rate limiting step.
Wow.
In terms of moving forward. Most patients, the electrolysis will be covered, because since the hair removal is medically necessary, then it would be covered by the insurance. What's some other things? Orgasm is possible. So we ask patients before surgery if you're able to have an orgasm. Most people, if they are able to prior to surgery, they can after surgery.
Wow.
Clitoral and vaginal orgasms. There can be a learning curve, and there are some people who, we want to be sensitive. Some people have pretty significant genital dysphoria. So masturbation is not something that they're comfortable doing. Mm-hmm. So we just sort of encourage people, because it's hard to compare like the before and after if we don't know what was going on before.
Totally.
But anyone who that is a goal, that's a pretty simple part of the procedure to maintain those nerves.
Wow.
Dilation post-vaginoplasty is a lifelong commitment. So you do have to dilate the vaginal canal. Dilating a vagina is also something that cis women do often for pelvic floor physical therapy.
Ooh, what is that? I can't picture.
Yeah, so when the canal is created, so the vaginal canal is created behind the bladder and in front of the rectum in a potential space. The space is sort of carved out, but then the skin is placed inside, so then it's not just red, raw tissue. So the purpose of dilation is, if you think about your pelvic floor muscles as sort of like a bowl, mm-hmm. and then you have the rectum and then vaginal canal and urethra that go through. So it has to be very strong because it's holding up all of your guts, essentially.
Yeah.
But it also has to be a little bit loose because things move through this space. So after the surgery, there's two ways really that the canal can become what's called stenosed, which is whenever it becomes narrow. And when it becomes narrow, it could close off completely. So it could narrow one way in that the muscles that are around the canal are just sort of squeezing in. So that's why I tell all trans women, there's no need for you to do Kegels or any squeezing of your pelvic floor. Your pelvic floor is very strong. It could also be that when the dilator is removed, so a dilator basically looks like a dildo, essentially. Wow. It's just like a long silicone rod. It is not pleasurable. So whenever patients do this and they're like, that doesn't feel great, I'm like, this is not what sex will be like. So don't worry about that. This is like a medical device. But you insert the dilator until it gets to the end of the canal. And then you're like sort of tenting the skin because you're trying to get the skin that used to be able to stretch and get smaller. We're sort of tasking it with staying at its peak stretch all the time.
That's
so
interesting.
We're training the skin to stretch and then also the muscles in like the horizontal plane to back off. What can happen if someone stops dilating is that if the skin stays touching for too long, so if like days or weeks pass, it actually fuses together. And when that happens, it's fairly impossible to reopen that canal. The tricky thing with these surgeries is like we can only do them once.
Yeah.
And that the timing has to be really right for people. So one thing that's sort of changed over the last 8 years or so that I've been doing this is like we're having younger people coming in to do surgeries, which is great. But there's a big difference sometimes between an 18-year-old and a 50-year-old in terms of who's going to be able to do this 4 times a day for the first 30 days. And then it's just like something to consider,
Totally. Yeah, I remember when I first started testosterone, I was having a conversation with a friend and he was talking about something he might have to do. I forget what it was medically, but he was like, well, if I go this route, I would have to take a shot every single week for the rest of my life. And I was like, dude, that's what I just signed up for with testosterone. He was like, I'm so sorry, I didn't mean it like that. But yeah, some of these things that come with transitioning. But if someone was explaining like brushing your teeth to you for the first time, they'd be like, twice a day, you got to get in there.
Yeah, that's a really good point.
Yeah. But yeah, that is very interesting. Like a sophomore in college having to do this medical upkeep where you're like, no, it's actually a pretty big deal if you don't stay on top of this.
Yeah.
Wow.
And then for phalloplasty or for transmask surgeries, it's much more complicated in terms of the actual phalloplasty. Metoidioplasty is a little bit more straightforward, but what people ask a lot is with the phalloplasty, if people can use it, if people can stand to urinate and that kind of stuff. So it depends on the patient's specific goals, but the specific in books, what the goals of a phalloplasty and vaginoplasty are to create functional, sensate genitals of the experienced gender.
Yeah.
So the way that the surgeries have sort of evolved over the years, I think the first goal was to be discreet. Especially with phalloplasty, people would take the grafts from someone's abdomen or their back because you potentially always wearing a shirt. But those areas don't have innervation, so people would have a penis, but you wouldn't be able to feel it. Wow. Not really great in terms of urination. So I think that it has evolved into, no, we're going to maximize our results here. And you have to sacrifice a little bit of aesthetics in terms of like, well, now you'll have the skin graft on your arm or your leg, but you'll have a much better result in that sense.
Yes. Okay. I've seen a lot about phalloplasty because I was using this website called Trans Bucket. I don't know if you're familiar.
Yeah.
Okay. Yeah.
Yeah.
Okay. That was for like top surgery, was helping me. Some of the images are pretty intense if you're not knowing that you're going in for seeing immediately after surgery photos.
Yeah.
Yeah. So is that the most current phalloplasty, its arm or its leg right now? It's a tube.
Basically. So the arm or the leg, those are the best. It's called a full thickness skin graft. So it's a healthy and reliable, juicy piece of tissue with good innervation that is used for a lot of different purposes. A burn victim, for example, if they need a good, healthy piece of tissue, they'll maybe take a radial forearm graft or they'll take a thigh graft. This is a unique surgery in that they're making it into a cylinder. So it's a tube within a tube. That same technique is used for esophageal cancers, but it just sort of changes things in terms of the size of the phallus. So if you take a piece of tissue, like if you think about like a square, like a Post-it note, and the blood supply is coming in from one corner, the corner that's furthest away is like furthest from the blood supply. The larger that tissue gets, the further that furthest part is from the blood supply. So whenever it comes to the graft, it's on the same discussion of some people want to choose their thigh, so then they don't have a scar on their arm. But sometimes that can just add some additional steps to surgery in terms of like a stage 2 or a stage 3, because it's pretty bulky and we have to do liposuction before we can make it into a urethra. There are some people who don't have a goal to stand to urinate. So we can do what's called a single tube. So we take the skin graft and just roll it once. So think about if you like take a sheet of paper and you roll it once to make the urethra and roll it another time to have the skin around it. Whatever the width of that original sheet is, the phallus is then 4 times that width. So often the thigh is going to be about the width of a soda can. I'm from Pittsburgh, so I want to say pop can, but I'll say soda so everyone knows what I mean, which is fine, but it's also a little bulky. And if someone's a professional horseback rider or something, like maybe they want to do a little consideration. However, also there may be reasons why someone doesn't want to use their arm other than having a scar. It could be if your job requires really good dexterity in both of your hands. There is a risk that you would have some less dexterity in the hand we take the grafts up. So there's just some like decision making. So basically what we ask phalloplasty patients, and this is in several literature resources, is to rank their goals in 3 categories. So one is, how important is it to you to stand to pee? How important is it for you to have penetrative sex? And how important are aesthetics? If your most important goal is to stand to pee and aesthetics, then like arm is probably going to be your bet.
Wow.
If standing to pee is like not that important to you, then maybe doing a single tube and like using your thigh is. So there's like a lot of decisions that go into it. Yeah.
Oh, that's so interesting. And what about getting it erect? I remember seeing something about an air pump.
Yeah. So the good thing is that cis men have experienced erectile dysfunction forever. So in terms of penis pumps, there's so much technology and advancement in this. But yeah, so there are hydraulic penis pumps. So there are some companies now, and there's one in Europe that's making penis pumps specifically for phalloplasty phalluses. But the ones that we typically use now are ones that are made for anyone with a penis. So basically there's just like a rod that is inside of the penis that kind of is like a long balloon. And then in one of the sides of the scrotum is a little pump. And behind the pelvic bone is a little reservoir filled with saline. And when someone is ready for sexual activity, they just like press the pump, it gets erect. And then whenever they're done, just hit the switch. There's other ones too that are less advanced, that are more of just like a rod. Some people will choose those ones because there's less risk of like it malfunctioning. But what people don't totally love about those ones sometimes is they make a sound. But I also think that's kind of cool. It's like, look what I can do.
Wait, what kind of sound are we talking? Like,
it's kind of like a ratcheting sound, like a yeah.
I mean, yeah, that definitely has its place. That's so interesting.
Yeah, there's also external ones if someone doesn't want to do the implant, and it's just basically like a ring. There's lots of ways. One thing that is a little different in terms of sex is that, and I'm just going to use gendered language for a moment so we're clear about different anatomy things, but the clitoral nerve is buried at the base of the phallus. And that nerve is also attached to the nerve that comes with the skin graft. So over time, that specific erogenous sensation to that area does grow to the tip of the phallus.
Wow.
But for the first several years, the sensation is actually going to be more at the base. So we actually talk to patients about masturbation and that kind of stuff, that you won't be able to do that how you think.
Yeah, like
you're going to focus at the base. Yeah.
Do you have $10,000 or more in credit card debt? Maybe you're even barely getting by making minimum payments. With credit card debt hitting record highs, National Debt Relief offers real debt relief solutions for people struggling to keep up. These options may reduce a large portion of credit card debt for those who qualify. You don't need to declare bankruptcy, and you may be able to pay back less than you owe, regardless of your credit. National Debt Relief has already reduced the credit card debt for more than 550,000 consumers. So don't wait. If you owe 10, 20, or even hundreds of thousands of dollars in credit card debt, you can now take advantage of this financial debt relief as the cost of living increases. To find out how much you could save, visit nationaldebtrelief.com. That's nationaldebtrelief.com.
Big news! Wayfair's tax refund sale is on now. Right now through March 2nd, you can score up to 70% off furniture, decor, appliances, rugs, and more. With fast and easy shipping straight to your door. Plus, amazing flash deals. Shop Wayfair's tax refund sale now to make the most of your refund with huge savings through March 2nd at wayfair.com.
Wayfair, every style, every home.
Yes. Yeah.
Yeah. Interesting.
I will also say that patients say, even before surgery, just from starting hormones, that orgasms do feel different when they're taking the correct hormones. I had a trans female patient. She was like, I just felt so much more internal and full body. And I just think that's really cool that even before the surgery. Yeah.
Yeah, definitely. I definitely feel much more external since being on testosterone.
Yeah.
And that was like such a learning curve too. And there are no resources for it. I mean, already having like a whole podcast or something like that about sex is pretty rare. And then even more specifically, like trans sex. So, but yeah, it's very interesting how much something like that can change. With phalloplasty, it's multi-step, right?
Yeah.
Is it 3 surgeries?
It can vary based on the donor site. So previously, the way that phalloplasties were done is it would be a multi-step procedure in that the first stage of a phalloplasty was essentially like a metoidioplasty. And a metoidioplasty is basically whenever we masculinize the exterior genitals of someone assigned female at birth by removing vaginal canal and then also lengthening the urethra and then releasing the clitoris.
Yeah.
So sometimes after that surgery, patients don't look a whole lot different than what they did pre-surgery. However, there's no longer a vaginal canal, which is very affirming to a lot of people. And second, they can potentially stand to urinate.
Interesting. Wow.
Yeah. So then some people at that stage will be like, I'm good here. Like, I'm going to just be here for a little bit. There's catheters involved. So it's sort of an intense process. And then someone who decides to move on to phalloplasty, we then basically just build on what we did in the first surgery. So we're sort of adding onto the urethra. Now that phalloplasties have been taking place more often, people are starting to do them in a single stage. So just the very first surgery is the whole shebang. And that saves people from having to take 2 big breaks off of work, twice having a catheter and that kind of stuff. But it's a pretty intense recovery for the phalloplasty. The patients stay in the hospital usually for about 7 days. The room is like 80 degrees because if you get cold, the 2 blood vessels that they just connected to make the phallus could constrict and then restrict blood flow into or out of the phallus, which would be an emergency. We'd have to go back to the OR.
Totally.
The other interesting is about these surgeries is a lot of people who have in surgery is because they're sick. A lot of our patients are very young, healthy people. About 2 days before their phalloplasty, they're like surfing in Santa Monica or something. And then I'm like, you're going to be in bed for 5 days at least, laying completely flat, shirtless. The room's hot. You're just staring at the ceiling. They're not in pain, like we're giving you pain meds and stuff, but it really starts to wear people down to be in the hospital. So we just really try to prepare people for that and tell them, like, if you have a switch, like, bring it.
Yeah, totally.
Bring it. Like, you have to pass the time.
You need to buy a new game. I know I've never told you this before, but that's on your homework.
Yes. Yeah. So that's one thing. There's Laura Jane Grace, the singer for Against Me, who she's trans. She said once in an interview, someone rudely asked her if she had surgery. And I forget exactly what she said, but she was like, I'm afraid to like have my wisdom teeth removed. Like, I want to do the surgery, but that's also part of it, that it's a lot of work. You also have to have someone with you who's willing to do bandage changes, transport to the hospital, that kind of stuff. So a lot of people, I think of surgery as sort of a finish line, and it is in a lot of ways, but it's also like a new starting line.
Totally.
So after that phalloplasty, basically a third stage generally would be like the glandsplasty, actually like shaping the phallus. Because when they first make the phallus, they're just making the tube and attaching it to your body and hoping that all of the plumbing works and stays connected. You don't want to like make incisions at the end of that tube because then that skin, we're already babying that skin a little bit. So then we just like make the head of the phallus as a later stage and then an implant as an even later stage. We don't want to put an implant in until those nerves have grown like at least halfway through the phallus.
Wow.
Because theoretically, like if you have an implant without sensation in the phallus, you could be having sex and it's breaking through the skin and you wouldn't know. So we just wait till it's safe to put it. No one has to have an implant.
Yeah.
A lot of people opt to not, but some people do.
Wow. Do you see a future leap in phalloplasty? Does it feel like there's a lot of room for some new techniques?
Not entirely, because it kind of is as good as it can be. It is a microsurgery. So you're doing a microvascular connection of little blood vessels. So that's just the dicey part where any graft, any skin graft, everyone is like crossing their fingers that the tissue lives.
Totally.
Whereas with the vaginoplasty, that's not really a consideration as much. So there's less complications in that sense.
Yeah.
Definitely with implants, I think there will maybe be some advancements, because one thing is that a lot of the implants are made for cis men, and the average trans male phallus is actually larger than the average cis male phallus.
Interesting.
So sometimes what happens is like the implant is in place, but it doesn't go all the way to the tip. They're rigid to here, but then like the very tip sort of doesn't have it.
Interesting. Yeah, it's not long enough.
Yeah.
Wow.
Yeah. So being able to accommodate basically like a longer phallus.
Wow. Oh my gosh. That's so interesting.
They probably will have some soon that like you can control with your phone and stuff too.
Yeah, literally.
Yeah. Like the pump in the testicle is also a cool party trick, but it would be cool too if you could just be like, look, I'm going to turn on my pump with my phone.
Let me put on some music and also this. Yeah, totally. Oh, wow. I wanted to ask you about the papers that you've written. What were those about?
I've done some work in HIV, but basically just writing PA papers about gender affirming surgery. So how, as a physician assistant, you can function on a surgery team and sort of be the middle person between the surgeon and the patient. My surgical team is fantastic. I'm obsessed with them. They're all so down for the cause and great people. But a surgeon sometimes has to have a little bit of distance. They can't care as much as I do.
Yeah.
Because it's hard, you know? So having someone to kind of bridge that gap a little bit is helpful. So basically just like descriptions of the procedures. And then like if you would encounter a gender nonconforming patient, whether they're pre or post-op, in a primary care setting, how would you treat them for gynecological concerns? How often does a neovagina need pap smears? That kind of stuff.
Interesting.
Yeah. Just like teaching people about the surgery. The last one I wrote, I didn't know this before I wrote it, but gender affirming surgery actually predates heart surgeries, transplant surgeries. It's actually like one of the oldest surgeries that has been documented. Yeah. So the first one was in like the 50s. Some people would argue that there was a attempted uterus transplant in the 50s. And some people would argue that's the very first like attempted organ transplant.
Wow.
So when people say like, oh, this like came out of nowhere and it's new, it's definitely not. I see patients that had a vaginoplasty, like many people, dozens of people that have had them in the 70s and the 80s in the United States, in South America, in Europe. And what's always amazing to me is like if I see someone on my schedule that I'm seeing for the first time and it's like vaginoplasty 1978 New York, I either think like, okay, I hope this person has been functioning well this whole time and there isn't some huge urological concern. 9 times out of 10, they're great. They look great. And I asked them, how did you find a doctor who would do this in the 70s?
Yeah.
Especially nowadays, there can be a lot of predatory surgeons. Just because a surgeon is willing to do something that you will pay them for does not mean it's the right thing to do.
Interesting.
It makes me cry to think about these surgeons back in the day attempting this with no guidance, really.
Yeah.
A lot of them like pro bono.
Yeah.
And all these patients say like he or she was so kind and amazing. I'm just like, that just makes me so happy.
Yeah. How did they find them? Was it word of mouth or something, you think?
Yeah, a lot of word of mouth. So yeah.
That's so interesting. Yeah. I mean, I even now, and this is like relatively recent, but I have friends who their top surgery was the first gender affirming top surgery their doctor ever did, or, you know, there's different things that are different about it than what the rest of us got. And they're kind of like, yeah, this was in Kansas. And he was just like, I'll figure it out. And you're like, yo, that was in 2004. Oh my gosh.
Yeah.
Rich history.
It's not always fair. I will do some education with healthcare workers and patients. And I tell patients, you shouldn't really be responsible for educating your doctor about how to treat you as a trans person in terms of medically. However, sometimes if you're in a small place and you have one doctor and they're like, let's roll, I'll do it, with the understanding of it is his first time or their first time. So it's just unique because it doesn't really happen to people with eczema or like, you know, where it's like, I've never seen this. I don't know.
Totally.
So what's good now is there's a network. There's so much education about this now. I've precepted PA students and medical students from USC, UCLA. There's a lot of people that are interested in this work. And I think that anyone who is interested in working in medicine in any capacity that is from the queer community, please do it. Because we need to have more people people in these spaces. And like, there's a lot of people on our team that are from the queer community. And I can just see it in the patients that they're like, oh, this is awesome.
Thank God.
Yeah. Yes.
Totally,
Yeah.
Totally. What are some of those resources? Where would people go?
Trans Bucket is a great one. There's also LGBTPA Caucus, CAUCUS. I think that's how you spell caucus. I like went in hard with the spelling, and then halfway there I was like, I don't know how to spell it.
It's a hard bail. You're like, you know, just look up caucus.
There's something called Out Network, which is like national network of LGBT providers. So not necessarily people who are going to be experts in all aspects of transitioning, but they are at least going to be affirming in your experience with them and maybe help connect you to someone who you might need to see for your specific goal.
With something like that, is it self-reported? Like, I would love to be on this in this database. Okay, cool. That's awesome.
So it's like an opt-in. Yeah.
Cool.
And then I think WPATH, they have like different resources of providers and that kind of stuff. WPATH is the World Professional Association of Transgender Health.
Oh, yes.
They're the medical society that sets forth the guidelines that everyone practices under. There's some really, really amazing people from so many different medical disciplines that work with WPATH and have written the standards of care. They have a conference every year. It's like Disneyland for all of us people that work in this. So it's really fun.
Wait, that's so cool.
Yeah. And it's interesting because I think something that's changed. I started doing this in 2015. And whenever I started doing conferences or different presentations, I kind of did it because I was like, I feel like no one else knows this stuff. So I'm just going to like submit to talk about this because even though like I'm not an expert yet or anything. And when I was first doing it, I would have people in the room, people that are interested. And then there was like a huge shift where I would have a lot of people at my talks. And then recently, like last year, I was asked to speak at a conference in Nashville for an association I won't say, in transgender health. And there's a small group of us who do this circuit. One person I want to shout out, his Instagram is Rectal Rockstar, Jonathan Baker.
Whoa.
He does gay men's anal health in New York. He's amazing.
Wow.
They had invited Barry Weiss to speak at the conference, who's very anti-LGBT. Which is weird because there's always like a keynote speaker. And the year before that was Simone Biles. And I was like, that makes sense. She's a gymnast. She's an Olympian. Amazing. She was like talking to us specifically about injuries with gymnastics. And it was really cool. And then they invited this outspoken anti-LGBT person to a medical conference. So the day before, I was like, I'm not coming. I'm not speaking. Don't ever ask me again. So then my friend who did go and did speak said it was the first time that there were PAs, just medical people in the audience who, after he does a discussion of anal HPV or like something totally unrelated to like transgender care, people are like, well, what do you think about kids transitioning? He's like, what are you talking about? So now it's that I can't assume that medical spaces are safe. And I think that before I would... Obviously, I know that trans people have bad experiences in healthcare, but now I realize there are a lot of people that work in healthcare that can be dangerous to the LGBT community.
Yeah.
I don't know. It just makes me really sad that people have to think about that.
Yeah, like that, it's Hippocratic Oath?
Hippocratic Oath, yeah.
Okay. Now, it's interesting that it's not immune to politics because it's like do no harm.
Yes.
If your politics are really raging in one direction, you might think something is harm when other people don't. Yeah, that's very scary.
So one thing that I tell trans patients is if you can, take a friend to pretty much all of your medical appointments. Just helpful to have another person in the room who can advocate for you or can say like, yeah, that wasn't right. On the same note, something that comes up with transmasculine, non-binary patients is if they have to go to gynecology or something for routine visit, I would say like take the female friend because then they'll assume like you're just there for her and then you both go back into the room. That kind of stuff instead of just like you're very male presenting sitting there and then people are like, you know, you can just be like, oh yeah, this appointment's not for me.
I love this like hack.
Yeah,
that's great.
So yeah, there's a lot of really amazing providers out there, but also just can never be too careful.
Is there anything that someone can do if they do encounter really bigoted medical providers, like other than just like not seeing them anymore?
Yeah, this is also one thing I like to talk about with patients is the discernment of experiences with people. For example, when patients come to our hospital, if they're admitted for many days, they're going to interface with so many people, like hospital staff, the people who bring their lunch. Not all those people are going to look in your chart and know why you're here. It's possible that you could be misgendered.
Yeah.
There's a difference between someone doing it by accident. It's always bad, but just so it doesn't harm the individual as much, like, okay, she didn't mean it.
Yeah.
But there's a difference between that and someone who is weaponizing pronouns and language against you. You can report any medical professional at any time for any reason. Sometimes those are just and sometimes those aren't, but I would expect that any organization that would get some sort of complaint like that about a provider would at least address that and talk to them. What kind of stinks is sometimes then people who are identified to not be safe, then it's like, okay, we're just going to have trans people not see them or have them not see trans patients. And I don't know any other area of medicine where you can just say, well, they're not good at it, so we're not going to have, and it's like, what?
Yeah.
And then it just like drives me crazy too. Yeah. When it's like someone's, okay, you've done a fellowship in vascular surgery, but pronouns is what you don't get.
Yeah.
That's the hurdle for you.
Intelligent people. Yeah. Totally. Yeah. That's very fun.
And I think what's tough too is like a lot of people in medicine in general, we're rule followers. We want to follow an algorithm. There's not a lot of room for creativity and nuance when it comes to diagnosis and treatment of things, except for in gender medicine, when there are patients who like make you stop and scratch your head and think, I really have to think about this for a second. And I think that makes a lot of people uncomfortable to not know exactly what's going to happen.
Totally. Yeah, I'm really curious about this because I was reading recently about, I think that this was more about top surgery, but the blueprint for this trans-affirming surgery was started in Holland. And a lot of the data, I guess at the time, trans-affirming surgeries were majority seeking feminization. And I guess there has been a big change to more people seeking masculinization, and that they were just like arguing that maybe some of that data isn't as like helpful anymore because there's just a lot more non-binary trans masc young people seeking surgery. Is that what you found? Is there a split?
Yes. I think that in the beginning of my career, the majority of the patients that we saw were, and when I say older, I'm just going to say for young people, it's like under 30.
Yeah.
So I would say they were like older people that wanted a binary transition, like a complete binary transition. And now we're having younger people who may or may not have been on puberty blockers that are wanting non-binary transitions. And I think that that is interesting. I sort of was thinking that what would happen is like over time, because it's like if you're looking at like the gender binary and you're thinking like, okay, a trans female is still on an end of the binary in a sense, like someone who wants to go from A to B. And I was thinking what I sort of thought would happen is that surgery in general would become less important for people as people started to think or understand I can be a woman with a penis.
Yeah, totally.
Whereas like, I think in the older generation of trans people, they're like, I have to transition to feel female.
Yes.
Nothing's a monolith. Not everything applies to all people.
Yeah.
But it is interesting because the research that we look at and the standards of care that have been written were sort of for people in a binary transition, people who have gender dysphoria.
Yeah.
Whereas someone who wants to have a non-binary anatomy, which is totally fine, it may complicate things because someone who is trans female is probably taking estrogen. Whereas some non-binary people might not take any hormones. But if we do a surgery and we remove your body's ability to make sex hormone, you have to take hormones then.
Totally.
And then it's like, well, which one are you going to choose?
And hormones feel a little binary, you know? Yeah, totally.
Yes. Yeah. So in the Standards of Care 8, which is the newest edition of the Standards of Care for surgery for trans patients, they've added non-binary and eunuchs and nullification surgery. So one thing that's come up sometimes is people who want everything to be removed. They don't want any genital anatomy. So it's kind of interesting.
Very interesting. Do you end up on a hormone cocktail just based on what you're looking for once everything has been removed? What does that look like?
Yeah, so it would really be case by case. And I think that what happens is that there's like hesitation at first for people to do trans surgeries because it was seemingly new and different. But then even that became a little routine in that, okay, these people are going to follow this route. And people want to be able to apply one set of rules for everybody. Wow. But what the new standards of care has in their wording of things encouraged, it's really between the provider and the patient on a case-by-case basis.
Cool.
We can't say that every single 18-year-old is not mature enough for surgery. There are some really mature 18-year-olds, and there are some really immature 50-year-olds.
Yeah.
You can't assume that just because someone is a certain age, they're a better patient. So there may be some people who after the surgery could do a mix. But what's important to know is that if you're a young person and you've had gonadectomy, essentially, it's ovaries or testicles removed, you'll probably get osteoporosis. It's really important for your bone health.
Yeah.
So someone at that age, you don't want to do that and then not take hormones.
Take hormones. Yeah, totally.
Yeah.
For me, it feels like non-binary has become a third category, but it's actually so much more of a wild card than that. And so I do love that approach of it's a case-by-case basis. There's no hard and fast rules for this.
Yeah. And it can change over time. I've met many patients who had no plans on doing bottom surgery, and then they got top surgery. And they were like, wow, now it doesn't feel aligned. Or people that got facial feminization surgery, and then they're like, oh, yeah. And it can continue to change. And I think that that's what is important to kind of understand, is that our goals change. And over the course of your life.
Yeah, new desires can come up. Or sometimes, honestly, it's just too overwhelming to think about everything at once. And so you choose small goal to small goal. And once you get something, yeah, you're right. I could so see having top surgery and being like, that felt so good. And now this other part feels a little bit more glaring than it did. And so interesting.
What I'm most interested in and looking for information about the experience of is non-binary patients. So while we're talking about that, because I've seen patients who are so dysphoric about their bodies, like they're unable to shower. They're unable to do basic self-care, and it causes actual serious health problems, like people that are trembling when we need to do an exam and that kind of stuff. And I just really want to honor that experience. I think everyone should be able to take hormones. If you want to be a woman and take testosterone, go for it. Everyone should be able to do everything. But keeping a special place for those patients that have suffered so much in their bodies from the time they were conscious, like 3 or 4 years old, than someone who maybe is exploring or is like more okay with their body. Not that it's not a part of the gender journey or expression.
Totally.
But just that I really feel for those people.
Yeah, that you see them. It almost reminds me of Maslow's hierarchy of needs. Sometimes basic humanity is intensely disrupted, and sometimes you're feeling okay, but you're feeling exploratory, and both things are incredibly valid. But yeah.
And I think it's going to be difficult over the next few years because people are going to want to apply research and data that was gathered from binary trans people and like apply it to non-binary patients. And it's not the same experience. I think one thing that's really cool too is a lot of people who are getting top surgery are choosing to not have nipples anymore.
Yes. Yeah.
And I think that's awesome.
Totally.
Because I remember when I was at the LGBT center, the first non-binary patient I saw was someone who identified as two-spirit. And truly in the presence of this person, I was like, you are neither male nor female. You embody something so different. And I wish that all people could spend time with someone who's just so comfortably trans or gender nonconforming and be like, tell me that you doubt this person knows who they are. Totally. Because they are so fucking solid. Sorry, I don't know if you can swear, but like, they're so sure of who they are, more than most people. So the non-binary gender identity, I thought I understood transitioning. But then once I met and interacted with non-binary patients, that's whenever my whole mind was expanded and I gained this ability for discernment. And I think a lot of people, when they want to say like, oh, it's like male, female, X, and XY, it's like, it literally isn't.
Yeah.
There are many chromosomal combinations of different sexes that happen. There are people who are born with genitals that are neither male nor female. So if that happens once, then that means it happens. There was this one person who kept saying like night and day. And I was like, yeah, and what about like dusk and dawn?
Yeah. It's so unpoetic.
Yeah. But it's so fun. Just the other day, I was seeing a patient for a pre-op for a vaginoplasty, and she's an older lady. She's very professional. Some of my patients have been NASA engineers, pilots, military, CEOs, doctors, the whole gamut. And this woman was sitting in front of me, and we're going over how she's going to prep for surgery and stuff. And she starts crying, and she was like, I wish I could just go back and tell my younger self it's going to happen for you someday. And yeah, and like, it's like, I can't. And I was like, get over here. Yeah. So having those moments. And I'm also really lucky in terms of healthcare positions. Like, my patients are so excited to have surgery. No one else's patients are walking in so pumped, And I'm like,
really, that was
so
a realization when I had top surgery at Kaiser, where the morning of surgery, I was extremely nervous, of course. And my partner was parking the car, and I was just in the waiting room. And the thing I decided to look up to like calm myself down, rows of chickens. Just scrolling through, being like, got another beautiful chicken. Oh, I was so scared and looking for comfort. And then that was the exact realization I had, where I was like, wow, this is so cool to be here for a surgery that is getting me to like a next step that I've dreamed about.
It's really a launch pad. Yeah. That's interesting because chickens are an animal. There's something that's called a bilateral gonadromorph, which is when animals are intersex.
What?
One of the big examples of that, is a chicken that is literally like down the middle, half chicken, half rooster. And it happens in birds. It happens in plants. Yeah.
Bilateral gonadromorph. Oh my gosh.
Yeah. Wow. Butterflies, it happens a lot. So the color of the butterfly indicates the gender. So it's like half a monarch, half different.
Oh
yeah,
my.
Just right down the middle. It's really interesting.
Wow. Stunning, honestly, to think about.
Gender Spiral is an original podcast from Audiation. This episode was mixed by Matt Noble, and music is composed by CMD plus Jasmine, courtesy of Molten Heart, with art by Joey Hahn and graphics by Michael Tyrone Delaney. The show is executive produced by Ireland Meacham, myself, Babette Thomas, my co-host, Allie Beardsley, and Sandy Smullins, with additional story editing from Susie Armitage.
Thank you so much to Kayla McLaughlin. If you liked what she had to say and you have further questions about surgeries, we might do a Q&A with her on our Patreon. So please reach out and let us know if that sounds interesting.
If you like the show, please head over to patreon.com/genderspiralpodcast to support us. You can also check us out at genderspiralpod.com, where you'll find transcripts for each episode and a link to leave us a voicemail.
And follow us on Instagram. It's at Gender Spiral. Subscribe wherever you get your podcasts so you don't miss a new episode. They're coming out every other week.
Audiation.